Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and I am joined today by Dr. Andrew Johns and Jon Fox. And our topic today is talking about what is testicular cancer. And to maybe let you both introduce yourself, maybe we'll start with Andrew and then go into Jon.
Sure. Thanks, Kyle. I'm Andrew Johns.
Sure.
I'm an assistant professor and physician at MD Anderson Cancer Center in Houston, Texas. And I specialize in genitourinary cancers and specifically testicular cancer.
Great. Thanks, Andrew.
Hey, I'm Jon. I was diagnosed with testicular cancer February 28th of 2022. I finished treatment that July of that year, and I've been in survivorship ever since.
Well, thanks so much for coming to join. Andrew, it's going to be great having your perspective on the clinician side of things. Maybe we can get into a little more of the biology kind of stuff. And Jon, you've walked the walk. You know what it's like to have been diagnosed with testicular cancer. You've gone through the treatments. So hopefully, by our powers combined, we can shed some light on what testicular cancer really is biologically, but also socially and how it affects someone's life. So maybe just kicking us off, Andrew, you treat testicular cancers. You trained with me at MD Anderson. So you're an active provider. Maybe from your perspective, can you tell us what testicular cancer really is?
So most testicular cancers, I'd say at least 95% are within a category of cancers called germ cell tumors. So these are cancers that actually originate from cells that are destined to become sperm in men or eggs in women. Germ cell tumors can affect women as well, but we're talking about testicular cancer today. And basically, these cells start to grow out of control in a way that can spread to other parts of the body and cause harm to normal organs in people. So that's my summary of what testicular cancer is.
Okay. And when someone's diagnosed with testicular cancer, what are the signs and symptoms that we tell people about?
Sure. So almost always, a patient presents with some sort of abnormality or discomfort involving one of their testicles. So that could be feeling a lump or a bump, pain, swelling. Occasionally, patients will report pain more in the groin area or maybe in the lower back. But I would say the most common thing is some sort of abnormality in the testicle. And then very rarely, patients will present as their first symptom with symptoms of basically widespread metastatic disease. So the cancer is already spread to the lungs or the brain, and they have trouble breathing or maybe even a seizure. Those are some of our most challenging cases, but it is a small percentage of patients who will have a presentation with those symptoms.
Okay. And do most folks who are diagnosed with a testicular cancer, are they usually able to feel a lump in the testicle?
Not always, actually. It's not an uncommon occurrence that a patient will present with something like low back pain or those things I mentioned, trouble breathing, a seizure, maybe a swollen lymph node in their neck, and come to find out after doing a workup that it was potentially testicular cancer, and we do an ultrasound of the testicles and find evidence of a small tumor in the testicle. And so basically what that means is that the cancer started in the testicle, but very early on, some cells spread out of the testicle and began to grow in other organs outside.
Okay. No, that's insightful, particularly for the individual who's listening here wondering, might they have a cancer, maybe testicular cancer? Knowing some of the signs and symptoms can really help people. Jon, we have just went through, what does the textbook say that someone should experience when they're diagnosed with testicular cancer? What was your experience like when you were first diagnosed?
Yeah, so about 2 weeks, I want to say, before I was diagnosed is when I first began experiencing symptoms. My first symptom was just pain in my left testicle. And by the time that I had experienced that, I then was able to notice visually that one testicle was the painful testicle was larger than the other. I think I remember very distinctly way before I had received my diagnosis Googling, like, is it normal for one testicle to be larger than the other? And it's like, yes, which is true, but not that much larger. And so it's a matter of proportion, right? And obviously, I mean, by the time I was diagnosed, um, the disparity in size was very, I would say, not just abnormal, but apparent. Even to a non-medical person would be like, this is probably something is wrong here. But before I had experienced the pain, um, perhaps if I had been more attentive and, I don't know, attuned to my testicles, maybe I would have detected something. I'm not sure. I'll never know. But it was certainly not as apparent as it was at the time of my diagnosis. And certainly pain was, I mean, there was a few other little clues along the way before I was diagnosed, but primarily and predominantly the pain in the affected testicle was my symptom.
Okay, and you're mentioning the size difference. And, I imagine for most people who are worried about testicular cancer, they probably will notice a lump or something. And you're describing a change that wasn't that huge. Like you had to look it up. Okay, it seemed subtle at the time. Was that true? Like it seemed subtle, and then you monitor it for a little while, and you're like, okay, something's going on, or how'd that go?
Yeah, so again, I think visually there was nothing noticeable until the point at which I had pain. Um, and with the pain, it started off as very mild. I remember the first time I ever had the pain, I just chalked it up to, sometimes you just get an ache or a pain and it goes away in a couple of days. And after, I think it was the third day of it not going away, that's when the eyebrow raised and I'm like, wait, this is strange. Like, this is not going away. It's persistent. And that's when I mentioned it to my dad, who's a physician, and he said, you should see a urologist. And he referred me to one that he knows, his own urologist. And I still had to wait, like 10 days or 2 weeks or something to get the soonest appointment. That sort of set me on the path towards getting it checked out.
And you mentioned the testicular pain. Was it constant? Did you feel it at night, or did it come and go? And
So it's interesting because I feel like in so many ways with my presentation and this particular factoid is a bit nerdy. I know Andrew and perhaps you too, Kyle, will understand. My tumor was like 90 or 95% embryonal carcinoma. So everything for me kind of just escalated very quickly. It started off the pain quite mild, but within a week, it was constant. It was like ibuprofen wasn't touching it. So yeah.
yeah, that's interesting. You're describing something that's, the pain at least wasn't subtle. And I feel like, correct me if I'm wrong, but for myself, and I think for a lot of other guys, subtle pains will linger for quite a while before we tend to get checked out. So, Andrew, I'm curious, this presentation that you're hearing from Jon, is this typical? Is this a little bit faster paced than usual? What do you usually see?
Yeah, I would say this is a pretty fast-paced progression of symptoms, what you're describing, but it does fit with embryonal carcinoma. So embryonal carcinoma really, of all of the sort of subtypes of testicular cancer, is the one that spreads and grows the most quickly. And in fact, we know that patients, even who have a very small tumor in the testicle, say 1 to 2 centimeters, that's predominantly embryonal carcinoma, the cancer will spread very early on, and patients will develop metastatic disease with a very small primary testicular tumor. And so, hearing you say that your cancer was almost all embryonal carcinoma fits very well with what you're describing.
And how common is it to have a testicular cancer like that? That's one of these aggressive ones.
So we know that, stepping back a little bit, for testicular germ cell tumors, there are two broad types, which are seminoma and non-seminoma, and about two-thirds are non-seminomas. So within that two-thirds, there are different sort of flavors or subtypes, if you will, of non-seminoma, but one of them is embryonal carcinoma. Hard to say exactly what percentage of cases that would be, but I would say, taking two-thirds and even dividing it equally among the four subtypes of non-seminoma, then you're looking at maybe around 15 to 20% of patients having a histology, as we call it, or subtype like what Jon had.
Okay. So, I mean, my takeaway from that is there are subtypes of testicular cancer that can act really aggressively. but it's not all of them that are that aggressive. So that's kind of the sweet spot where I think people can hear that maybe and have some hope that if they are concerned about a testicular cancer, we'll go into some more reasons for optimism, but it's also a reason to not sit on it and, and take your time. Because John, even you were aggressive about your workup, but it still took, 2 weeks.
Yeah, and I think in those early phases around the time I was diagnosed, what I didn't realize at first was how much room for optimism is a good word, and hope that there is and was, um, because all I could think about and focus on was, well, so many of the cases of testicular cancer are localized. They're not metastatic. They're not this. And so I'm thinking, well, all the typically, used reasons for hope don't apply to me, which is not what I mean. That didn't apply to me, but there were other reasons to be hopeful that I hadn't discovered at that point. Um, but yes,
Well, and we're talking about your workup and your frustration around a delay in evaluation is pretty common. We have our system isn't perfect. It's better than some. It's probably not as good as others, but people do experience delays in getting their cancers diagnosed. We know that. And it's horrifying, particularly if if you know you're worried about a cancer or you're diagnosed with a cancer and we need to do your staging. People experience delays throughout all of this, and it's really upsetting to a lot of people, rightfully so. I think all you're thinking about is the tumor's growing, it's potentially spreading. Like, here's time, we're waiting, just doing nothing while this is taking over my body.
on that theme, it was a few days after I was diagnosed that I had my first CT scan, which, by the way, also was going to take like a week or more, and fortunately, a doctor was able to intervene and really advocate to get that pushed up. And then with that showed that I did in fact have metastatic disease, and my orchiectomy, which was the surgery to remove the testicle, was scheduled for something like a week after that. And I actually got a call at work the next day from the surgeon himself, who was like, "Do you think you could come in tomorrow?" Like, after he saw my CT scan, which I'm so thankful that, and he kind of like, and I'd be really curious, Andrew, like, this is something that you've done commonly all the time. They kind of finagled it where like you would go into the emergency room, say that you're in pain, blah blah blah, and like that's how he was able to get me on the schedule for surgery sooner.
Yeah, unfortunately, this is a common pain point, I think, for patients and providers in our healthcare system is, we try as hard as we can to triage and prioritize, patients, especially those in your situation, where basically the first appropriate treatment was probably to have that testicle removed, but you also already had known metastatic disease that needed chemotherapy. And so, the at least at our institution, really the most important thing that we do is just have open lines of communication between the people who are literally receiving the first phone calls from patients about needing an appointment, all the way up to the physicians and our teams of advanced practice providers and nurse navigators and so on. That way we can try to get patients in sooner who absolutely need to be started on treatment right away, and really just think rationally and also compassionately about how we can best help our patients.
Yeah, and even, backing up a little bit, John, you'd mentioned, or Andrew, you'd mentioned ultrasounds. John, you mentioned a CAT scan. So back when you were worried you had this testicular mass, there's pain, might be cancer, what was the workup for you, John?
So I made that appointment with the urologist, like I mentioned, and before that appointment even arrived in time, I had had a night where I was woken up by pretty severe abdominal pain that I can't describe it other than to say that it felt alien. It was not like other abdominal pain I've ever had, and it really, it went away, it subsided eventually, but it really spooked me. And so that next day, I told my boss that I sort of mentioned what had happened and that I wanted to go to urgent care and just get checked out. And so I had gone to urgent care, and between that and my, enlarged testicle, they're like, you need to go to the emergency room and just like get a full workup. So I called my dad. My dad brought me to an emergency room, and I had the sonogram, the ultrasound, sonogram, whatever. That actually, the results of that um, said that was the first time that cancer was mentioned. However, it was the last thing mentioned in the differential diagnoses. It said maybe epididymitis, maybe something else, and the last phrase was less likely to be a tumor. I would also be, when I finish answering this question, I'd be really curious, Andrew, if that's common, if that's uncommon, what. So that's when the idea of cancer first entered my brain's radar. But it was still like, okay, this was probably worst case scenario. It said less likely, right? And then they actually, after evaluating me, I don't remember everything they did, but they were pretty convinced that it was epididymitis and put me on antibiotics and sent me home with antibiotics. But before I left, they were like, we just want to we were wondering why they wouldn't let us leave, and they're like, we just want to get markers before you leave. And at the time, I didn't know what the heck markers meant. But thankfully, again, very thankfully, they drew tumor markers. And I didn't know what they were even doing when they were taking my blood for that. And then the results of that, which of course was the big red flag of having testicular cancer, actually came in the same morning of that original urologist appointment that I had scheduled. So between getting those results and having the life scared out of me, and then going to the appointment and getting it confirmed by the urologist, that's how the workup actually led to my diagnosis.
Okay. Andrew, is that common that you have, he had an ultrasound, and you were mentioning before, sometimes, particularly with embryonal carcinomas of the testicle, you can have small nituses of cancer. And I think you used that as an exact example. So is this something that's commonly seen across testicular tumors, or a little more rare?
Or this equivocal ultrasound finding, not sure whether, yes, absolutely, especially for smaller tumors. Things can be identified as possible cysts, which are benign fluid collections. Infection, you mentioned epididymitis is a common alternative diagnosis reported on ultrasound. And so really the key in situations like that is due diligence. A repeat ultrasound within a few weeks after the initial ultrasound, checking tumor markers like you mentioned, potentially even more advanced imaging like an MRI, seeing a urologist, but really just making sure that everybody's comfortable, most importantly the patient, that cancer is not the explanation for the symptoms and the findings on the ultrasound.
And it sounds like the key here to John's diagnosis, at least in the beginning, was these tumor markers. Andrew, can you explain what tumor markers are and why they're useful?
Sure, absolutely. They've been really a very helpful tool for many decades now for managing testicular cancer from the physician's perspective. So traditionally, there are three tumor markers that we use for testicular cancer. These are blood tests, basically, that are elevated in patients who have testicular cancer. So the first is HCG. You may be familiar with HCG. It's also the pregnancy hormone that's used to detect pregnancy in women. But men should not have detectable HCG levels. And so, in fact, so to speak, a simple off-the-shelf test for HCG is a urine pregnancy test. And so a male with a testicular cancer that secretes HCG could take a urine pregnancy test and likely it would be positive. But anyway, we use blood HCG levels to monitor certain testicular cancers. Typically, choriocarcinoma, which is a subtype of non-seminoma, makes high levels of HCG. Embryonal carcinoma and seminoma can make sort of lower levels of HCG, but these should not be present in men without testicular cancer. There are a few possible causes of a quote false elevation of HCG, which can be low testosterone state or hypogonadism. Some groups have reported that marijuana use may cause HCG elevations, but these are typically very low level elevations of that tumor marker. The second one is AFP, or alpha fetoprotein. This normally should be less than 20 in a person without cancer, but is elevated, especially in patients with yolk sac tumor, which is another subtype of non-seminoma. And then the third is LDH. LDH is sort of nonspecific. It can be elevated in patients with infections or other medical conditions, but we do see pretty high elevations in patients with seminoma and also embryonal carcinoma and choriocarcinoma as well. So that's the panel of three tumor markers that we would always check in a patient like you, John.
Okay. And John, it sounds like they drew these. Something about them was so concerning that then what happened?
I got the results through my chart that morning of the urologist appointment, which was a week after I had been something about a week after I'd been to the emergency room, and I saw that they were all significantly elevated, not just like a little bit out of the reference range. We're talking hundreds over the ceiling. And so to me, I mean, again, I think intellectually it was like the writing was on the wall, but I was still just they wouldn't diagnose me over the phone. Of course, I received a call from the hospital, and they were like, this isn't a diagnosis, blah 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 blah, but make sure you see a urologist or something like that. I was like, well, I'm seeing one today, and I was still holding on to hope that maybe there was some alternative explanation, and especially since I hadn't received a diagnosis yet. And then so I went to the urologist, absolutely terrified, just hard to describe, hoping for a miracle, basically. But as soon as he looked at the tumor markers, and after seeing my testicle and then looking at the tumor markers, he was, to him, it was like there's no doubt that he was diagnosing me with testicular cancer. And so that's how the diagnosis came to be.
And when you got that diagnosis, did you know much about testicular cancer ahead of time?
I didn't. And it's actually quite strange and crazy to me that I didn't, because I've since learned, of course, that it's not at all uncommon. Something like 1 out of every 250 men will get testicular cancer, thereabouts, which it's also funny because when I said that to my dad, he's like, well, that's rare. To me, that doesn't sound that rare. If it's like, oh, you have a 1 in 150 chance of getting a cancer, that feels like I don't like those odds. So, and it's young men. And again, so I feel like for my age group, I feel like there should be a lot of awareness around this. And for whatever reason, there had never been for me. So yeah, no, it was completely new to me. Not like I'm sure I had heard of it, but in the same way that you hear of, you know, brain cancer or a person who has not been through a medical episode in their life, you hear of things like pancreatic cancer, but it seems so foreign to you.
Well, with that in mind, and this guy just told you you almost certainly have testicular cancer. What was your perception? Did you interpret that as a death sentence? That would be my inclination, I suppose.
So I think it's interesting because I didn't necessarily at first interpret it as a death sentence, but I think that was because at the time of my diagnosis, it was not yet discovered that I had metastatic disease, which I can't quite remember the order in which things happened, but I think if I had been told that as well at that exact moment, I would have interpreted it as a death sentence, which of course I now know is not true at all. But metastatic cancer to me would have been a death sentence. Even like a best case scenario would have been a slow death sentence in my mind at the time. I think that was also the first time, and only a small fraction of it sunk in, but it was the first time that I began to hear and learn the idea that not that it's good that you have testicular cancer, but it is a very treatable, chemosensitive cancer, even in the metastatic setting, which is unusual for a cancer.
Yeah, I think that's absolutely true. Most of the time, if solid tumors have spread throughout the body, we don't usually consider those curable. There are exceptions, but testicular cancer is one of the major exceptions. And we'll go into that in a little bit. But Andrew, back to you. If there is a concern that someone has testicular cancer, what's the standard workup they should receive?
So for ultrasound of the testicles would definitely be sort of the starting point. Lab tests, particularly those three tumor markers that I mentioned, the blood tests for LDH, AFP, and HCG, And if there is a finding concerning for cancer on an ultrasound, then a CT scan of the abdomen, pelvis, and possibly the chest as well would be indicated. And then we don't typically biopsy tumors or suspected tumors in a testicle, just because the yield of that can be low, it's painful, and we can use ultrasound criteria pretty reliably to predict that a patient will have a testicular cancer. And so typically, if a cancer is suspected based on ultrasound, then surgery to remove that testicle would be the way that we would both treat it and confirm the diagnosis by looking at the testicle under the microscope with pathology.
And Jon, is that what happened to you? They were worried that there could be testicular cancer. You had a painful testicle, and they proceeded with surgery?
No, it wasn't until I had that diagnosis that was pretty convincing, that surgery was planned. So it wasn't just operating off of strong suspicion. That was
So it was
that
after
was
the CAT scan.
well, even I would say before the CAT scan, but then certainly, if there was not that there was any doubt based on the tumor markers and everything, but if there had been any doubt, the CT scan would have certainly squashed that doubt.
Okay. But you had mentioned you had the orchiectomy, which is the surgery for removing a testicle.
Yeah, so when I was diagnosed and I hadn't yet known that I had metastatic disease, it was suggested to me that minimally I'll need the orchiectomy, and that's when I had first heard of the RPLND surgery as being a possibility. It was suggested to me there's the possibility of a cycle of chemotherapy or something. We knew I had to do the surgery. Once I had the CT scan results, knew certainly I would have to do chemotherapy, but step one was doing that orchiectomy surgery. Yeah.
Yeah, and I'm curious, since this is a common recommendation for folks. What was your reaction to hearing that you needed to have the testicular cancer removed surgically? Like you had to have the orchiectomy. I'm just curious how you interpreted that. How did you feel about it?
Yes, it's a great question, and I sometimes wonder if I would have felt differently if the context had been different, if I was at the time only stage 1 disease and, still would have been a scary unknown, like, am I going to get a recurrence? Is this going to show up as metastatic disease one day type of situation? And maybe, or even just if that was the extent of the treatment at the time, for the time, maybe its weight and significance would have been magnified for me. I wouldn't be surprised if that was the case. But for me at the time, honestly, my reaction to like, oh, you have to have the surgery to remove text, I was like, thank goodness, get it out. Like, and in the context of everything else, it was the part that I was the least afraid of. I was much more afraid of the chemotherapy and so on.
Well, it's interesting because there's some, I would say the female equivalent to this is having a breast surgery, and that can be really identity changing when, a large part of your body that's visible to other people is altered. Testicles aren't visible to other people, but still, it's a identifying part of the male anatomy. Did you have any sentiments around losing it? Or, I mean, you were at the time, you're told you have disease everywhere, you're going to need these other things. So in the anxiety bucket, this was a bit of a drop in the anxiety bucket. But yeah, I'm just curious if you could elaborate a little more.
Again, a great question. I think the visual component, the change, the identity, I think I would say certainly at the time it was so minuscule. I think as time has gone by, there's a little bit more of that, although I would still say in the grand scheme of things, it's much more in the background compared to other losses and issues and challenges. I think, again, the context that mattered to me that was significant was I was told very early on that if you're a male and you have two testicles that were otherwise healthy and you have to lose one because of a situation like this, that by and large, it's not going to your remaining testicle will step up to the plate, so to speak, and perform any testosterone production, etc., as needed. And so functionally, I was told I would be more or less the same, and that was really what was important to me. So not that I'm happy to part with any part of my body, but I would say I think what the most significant issue with that is now I feel like, well, now I'm only down to one. Like, I can't lose this one. Nothing.
And Andrew, would you say that that's kind of your medical perspective too, that having one testicle removed for testicular cancer or whatever else is, compensated well for the body, doesn't really cause long-term issues?
Yeah, that's correct. Most of our patients, if they wish to have children after having one testicle removed, it's still possible. Testosterone production can return to normal levels. So I agree with John's perspective. I think that's pretty sound from a medical perspective as well.
Okay. And so we talked about the orchiectomy that John had, and I want to talk a little bit about the other therapies that one who may be newly diagnosed with testicular cancer, you're worried about it, might expect. But I think in order to do that, Andrew, maybe we can set the stage real quick about general staging for testicular cancer. Can you describe what the stages are in general terms?
Yeah, absolutely. And this is something that's really unique to testicular cancer, how we stage it and how we approach sort of the prognosis. So first of all, there's no stage 4 testicular cancer. So there's only stages 1 through 3. So stage 1 is cancer that's limited to a testicle. Stage 2 is when the cancer has spread to the lymph nodes in the back of the abdomen. So we commonly call these the retroperitoneal lymph nodes. They're part of the immune system that's located kind of around the kidneys. And we also commonly, and especially our surgical colleagues, will call this the landing zone. So this is basically the first place where cancer cells typically will spread after leaving one of the testicles. And so stage 2 disease is cancer that's spread to those lymph nodes there. And then stage 3 is really any disease that's spread beyond those lymph nodes in the back of the abdomen. So that's our staging system. And then as far as metastatic disease goes, we have sort of a parallel system, which is our risk stratification or risk classification system. And that basically is broken into what's traditionally been called good, although I like to say favorable, intermediate, or poor, which I typically like to call unfavorable risk disease. And those three categories correlate pretty well with long-term survival for patients with metastatic disease. So patients who have favorable or good risk disease, the long-term survival, even though it's metastasized outside of the testicle, is above 90%. For intermediate risk disease, I would say it's probably around 80%. It sort of depends on what data set you look at. Poor risk disease or unfavorable risk disease, again, depends on the data that you look at, but somewhere between probably 50 and 70% long-term survival. So that really is what correlates most strongly with the outcomes for metastatic disease. And risk classification is based on the tumor marker levels. So the higher the tumor markers, the more unfavorable risk disease you have. And then where the cancer has spread. So for non-seminoma, if the cancer has spread to the liver, the bones, or the brain, it's sort of automatically unfavorable or poor risk disease. But cancer that's spread to the lymph nodes or the lungs can be intermediate or even favorable risk disease. And then for seminoma, actually, there is no patients are classified as having poor risk or unfavorable risk disease. Everyone has either intermediate or favorable risk. And the main thing that dictates for seminoma is where it's spread to. So if it has spread to liver, bones, or brain, then it's intermediate risk. Otherwise, it's typically considered favorable risk for seminoma. So when I talk to patients, I really hone in on the risk classification system more so than the actual staging itself.
Okay. And, from what you're describing, um, this is, not everyone is poor risk, of course. And even those who are the poor risk phenotype or their tumor is the most aggressive of the tumors, however you want to think about it, uh, over half of them are having long-term survival.
Yeah.
And when you say long-term survival, what do you mean?
I mean, living at least 5 years past diagnosis and, really probably having a near normal life expectancy is the true definition of that. I mean, we have occasional patients who have a very late recurrence of cancer after the 5-year mark. But to me, it's, living 5 years past initial diagnosis and treatment and not having any evidence of the cancer still being around, with an expectation that likely life expectancy will be close to normal, at least in the long term.
Well, and then, other subgroups, favorable seminomas, many of these patients are living what we think is really being cured.
Yeah.
And you put that statistic above 90%.
Yeah, for favorable risk disease, depending again on which data set you look at least 90%, maybe even above 95% of patients are long-term survivors and cured of their disease if they have favorable risk metastatic testicular cancer. The key to all this, though, is really complete and appropriate treatment of the cancer. And so, things have to be done correctly. We have very well laid out guidelines and algorithms for how we manage different situations. And so really being managed by a physician or group of physicians who are comfortable and familiar with those guidelines and protocols, and ideally in coordination with a cancer center that sees a lot of patients with testicular cancer are really keys as well to having outcomes like that, or even better potentially.
Well, I couldn't think of a better segue now that we've talked about where disease can spread to, how we think about how aggressive to be. Andrew, can you speak to what the treatments are for testicular cancer?
Yeah, so for stage 1 disease, really surgery to remove the testicle containing the cancer is the mainstay of treatment. After that procedure's happened, the tumor markers, if they were elevated beforehand, if the patient only has stage 1 disease, the tumor markers should all go to normal or undetectable if it's in the case of HCG. And then we look at the cancer under the microscope and really identify is it seminoma or non-seminoma, and then does it have features that place the patient at high risk of developing spread outside of the testicle. And in that case, for some patients, we may consider chemotherapy, a short course, or maybe even surgery to remove those lymph nodes in the back of the abdomen to reduce the risk of the cancer spreading or coming back. And then thinking about metastatic disease, so stage 2 or stage 3, stage 2 disease, chemotherapy is certainly an option for patients with stage 2 disease. For seminoma, in cases where the lymph nodes are only a little bit enlarged and the involvement of the cancer is limited, radiation or surgery are potential options to cure patients as well. And then for non-seminoma, chemotherapy or in some cases surgery to remove those lymph nodes in the case of stage 2 disease. For stage 3 disease, really chemotherapy is the first treatment for all patients. And then after chemotherapy, some patients may need additional treatment. So that could be a surgery to remove the lymph nodes in the back of the abdomen, which is called an RPLND or retroperitoneal lymph node dissection. It could be other types of surgeries to remove, for example, a spot that's left over in one of the lungs or the liver. It could be radiation in the case of seminoma. And some patients go on to need other treatments, such as higher doses of chemotherapy with stem cell transplant. And so each case is a little bit different, but I would say chemotherapy is the mainstay and first treatment for really all patients who have stage 3 disease that's spread outside of those lymph nodes in the back of the abdomen.
Okay, so it sounds like for the person who doesn't yet know what their stage may be, or they feel a lump and they're just wondering, what could potentially be in my future if they're worried they might have testicular cancer, chemotherapy, radiation, and surgery are all modalities, are all treatments that we do sometimes use for the treatment of testicular cancer.
Yes, absolutely.
So, Jon, you had mentioned receiving some of these. What did they do? What was the initial treatment plan for you?
Received all of these, unfortunately.
All of these. Oh, and before we kick off, what was the stage that they gave you?
Right. So I believe eventually I believe my official stage was 3B. It was a little bit, I think initially I was 3C. I think even in the eventuality, it was a little unclear whether I fit more appropriately into 3A or 3B. I'm not quite sure what makes someone A, B, or C, but sort of ballpark 3B. And I was initially put in the unfavorable risk category. I like the favorable and unfavorable terms better than good and poor. But of course they said poor risk category, and then as soon as I was put in that category, I was very well aware of that 50 to 70% that you mentioned, Andrew. So, that didn't feel good to me. And I also knew that, well, I can't, I think maybe even the intermediate risk too, but certainly the poor risk, it's 4 cycles, not just 3 cycles of BEP, of the chemotherapy regimen. So, yeah, so I was told poor risk, not so good. But it turned out that because I had listened to podcasts and interviews much like this one, and I had heard this explanation like Andrew just gave us, right? And so based on that, I didn't understand why I was put in the poor risk category because my tumor markers, while significantly elevated, were all less than 1,000. And the only distant metastases that I had were my lungs. So I didn't have any mets in my liver, bones, or brain. So to me, I felt like that should be good risk, or certainly at least medium risk. And when I asked my oncologist why I was, poor risk and set for 4 cycles, his answer was that I did have this, one of my lymph node tumors was quite large, and it seemed to be infiltrating or invading my psoas muscle and caused tremendous pain. It was a whole thing. I had to be on a fentanyl patch. It was, and he said that they discussed it at a tumor board, and it was concern of very, very aggressive disease. And by the way, I just want to mention that this is not some local hospital place where I was. This was. I won't mention the institution name, but this was a major. This would be listed as like a top 20, 25 cancer center in the United States. And I did some digging. I tried to, sure you guys both know, certainly Andrew, you probably know the legend, the saint of a human being. That's Dr. Lawrence Einhorn. Was able to get in touch with him, give him my information, and he's like, no, we'd probably put you in good risk, or certainly treat you as good risk. And so then I went to a different cancer center and got another opinion. And before I could even get the full story out of my mouth, the oncologist, who's now still my oncologist, he was like, no, you would be good risk, at worst medium risk. We would only give you 3 cycles. So eventually I was good risk, maybe somewhere between good and intermediate risk, maybe good risk, and only did 3 cycles. So I did 3 cycles of BEP. I know some institutions do 4 cycles of EP. So that was the chemotherapy. And then I did have to have the RPLND, which I have a very specific question that I want to ask Andrew about that as well, but I'll pause there.
Well, it sounds like you were very successful in haggling down your risk profile. You're like shopping around to different doctors. Okay, he's got intermediate risk. If you give me a good risk, I'm going to go to you. But Andrew, one thing I want to follow up on before we go into the next question is this characterization ambiguity. I mentioned a lot, I'm in lung cancer, and staging is not as clear cut as it always may seem. And it's dynamic over time. Our staging stuff changes. Sometimes tumors behave weird. And I'll say there's a lot of situations where reasonable minds may differ. And for a patient, this person who's receiving the care that we're him and hawing about, that's like super distressing. And I get that. So Andrew, I'm just curious, can you speak to how common it is to have staging or risk profile ambiguity in a testicular cancer situation?
I would say it's not too uncommon. Yours sounds like a situation where you had disease or cancer involving lymph nodes, but because of sort of the high quality of imaging that we have available nowadays, there was evidence that it was sort of pushing into a muscle. Certainly you were having pain related to that muscle being there. So you did absolutely the right thing, which was to get another opinion about the situation. And so I would encourage anyone who's unsure about what they're being told provided that they're not an extremist or, in need of emergency treatment, to seek another opinion if they feel unsure about what's being told to them. But also just speaks to the importance of, multidisciplinary, as we call it, management of patients with testicular cancer. So having a group of physicians who have different areas of expertise and different levels of experience reviewing images, reviewing cases, looking back on experience with prior patients to really shed light on what's going on and what the proper treatment would be. And as Kyle said, at the end of the day, different people with a high level of expertise can have differing opinions about cases. And I think it's important, just from a physician's perspective, be transparent with patients. And so, for example, saying, I'm not really certain whether this should be considered intermediate or poor risk disease, but stepping back, we know that, it sounds like your case was embryonal carcinoma, which we know is probably the most chemotherapy sensitive of any of the main subtypes of germ cell tumor. Therefore, BEP times 3 is likely adequate treatment. That is, but other people could disagree, and this is why. Just being upfront with patients about that and having a risk benefit discussion, doing, shared decision making, right? Some patients would say, you know what, I will not be able to sleep at night if you don't give me that 4th cycle of BEP. I'm going to be worried every day that I was undertreated, that I'm going to need additional treatment. And if a patient really feels strongly, knows themselves that way, and the physician, has some, question about how many cycles are correct, then, it may be appropriate to give a 4th cycle of BEP. Other patients will say, look, I want as little chemotherapy as possible. I accept that this may be 1 cycle is too few, and that may confer a small increased risk of the cancer coming back, but I really do not want a 4th cycle, or I'm comfortable with the idea that 3 is likely enough. That's a perfectly reasonable approach as well. And so just having a good back and forth conversation with full honesty about the limitations of our data and our guidelines, because, these cases like what you described are not written into the guidelines, right? And so it becomes on a basis of experience and expert opinion and multidisciplinary discussion.
Well, then leaning on that, as medical oncologists, we're not commonly in a position as a whole where we can cure people. So I think when the ability to cure someone is on the line, my bias at least is going to be leaning toward more aggressive, because I don't want to look back and think, what if I didn't give that last cycle, could I have potentially saved someone's life? So yeah, I think, these are tough situations. And I think the difference you're seeing from provider to provider, and I'm happy, Jon, you found something that was a good fit for you. And it sounds like a couple people agreed, which is really helpful. But when the stakes are so high, it can be tough.
Yeah, for sure. And I mean, listen, as much as I didn't want to have that 4th cycle, I mean, just hearing the one opinion, I mean, granted, Lawrence Einhorn, the godfather of testicular cancer. I mean, if you're going to go by one opinion, that's the opinion to go by. But I was like, okay, but let me verify that. Let me go to another top expert and see if they feel the same way. I also just wanted to point out what you said, Andrew, about the shared decision making. I really, really value that. I feel like I didn't get enough of that in my care, and just even beyond cancer in general in healthcare. I really wish more providers, I mean, certainly in the case of something as serious and impactful as cancer and its treatment, right, would approach it that way and be like, here are the benefits, here are the risks. What are your values? What are your risk tolerances and comforts? What are your priorities? Like, I feel like having those conversations together, because it is hard to make it one size fits all, and you have to it's like, well, there's always a trade-off, and I think you need the patient's perspective to inform what trade-off feels worth it to them.
Absolutely. And I think we want all of our patients to be comfortable with the treatment they're receiving and the rationale behind it, and also the limitations of the data that we have that support what we do, because there are always limitations.
Yeah, and so Jon, kind of continuing the narrative here, you received 3 cycles of a pretty aggressive chemo. As far as all the chemotherapies we give, the chemo you give wasn't a gentle one. How did it go?
Yeah, so okay. The first cycle, I like to say that it's a tease, because after the first cycle, I thought to myself, listen, that was highly unpleasant, but I thought to myself, I can do this. I mean, obviously, it accumulates, and the second cycle was harder. Um, Still, but I got through it. The third cycle was brutal, and remember, I had done that whole second and third opinion and pivoted my care after just about after my first cycle ended. So this was before I even had the experience of going through the full chemotherapy treatment, but certainly by the end of the third cycle, I was it was that the third cycle was really hard. Um, the first two, I mean, they were not easy, but you know, the third cycle was really, really hard. And I can only imagine that the fourth cycle was even more would have been more brutal. Um,
What
so
was hard about it? Like, what were you feeling?
yeah, so for me, so again, I would say like there was a storm of little things which I would comparatively are forgettable. There was one thing that was not pervasive throughout the chemotherapy. For whatever reason, it seemed like whenever I started a new cycle, maybe it's because that's when I got, I don't know what it was. It seemed like whenever I started a new cycle, it would be like one weekend, first weekend I would get the horrible throat pain. Um, that was awful, but that usually only lasted a few days. Um, Other than that, it for me the worst and most pervasive symptom by far was the nausea. Um, I didn't have any vomiting, but just the third cycle is just like intense nausea, just 24/7 sick to my stomach. That and I remember the first cycle that lasted for maybe a few days or so, maybe something like 3 or 4 days. The second cycle it lasted for like a week, and then the third cycle it lasted for maybe a month or something close to a month. Um, that was I mean, again, I'm glossing over. There were lots of horrible things throughout, but what stands out, what I remember as like this was so brutal was the intense nausea.
Andrew, is that representative, or what are the common side effects that patients with testicular cancer experience from their chemo?
Nausea is a very common side effect that patients receiving chemotherapy like BEP will experience. I would say the severity of it and exact specifics vary from patient to patient. Most patients, when they have nausea, it's typically at its worst around, each what we call cycle is 21 days, and nausea is typically at its worst between days about 5 and 10, I would say. Other patients, though, don't have much trouble with nausea, but they may report pretty bad fatigue. Usually, fatigue is at its worst around between days 10 and 14 because that's what coincides with decrease in blood counts and kind of effect on the bone marrow from chemotherapy. Ringing in the ears or tinnitus is another common side effect of this chemotherapy. Typically, patients will experience this also around day 8 or 10, and it'll sort of get better as the cycle goes through, and then it'll happen again around days 8 and 10, and then get better. But I typically counsel patients that the nausea, fatigue, and the ringing in the ears are the three biggest side effects and most common things that we see with this chemotherapy.
Okay. So then, John, you got the chemotherapy cycles, you got three, but then you mentioned you got other therapies too. So what happened after chemo?
Yes. So I was told, okay, well, after my first cycle of chemotherapy, this was like sort of the very first piece of shining good news in the whole experience, which was that my tumor markers plummeted after just the first cycle, and it's like, oh, thank goodness. And of course, and then by the end, they were normal. Um, and so I knew based on that that I had a good response to the chemotherapy. And Andrew, you mentioned that embryonal carcinoma is probably the most chemosensitive subtype. I'm sure it's because it's so aggressive, right? It divides so rapidly. Um, so I was feeling hopeful that I was going to be done with treatment, but I was told that I needed to still have the RPLND. And once again, I wanted to double check and get multiple opinions on that. And so I emailed Dr. Einhorn again, and he confirmed yes. And I am sure. Actually, I'm sorry. I don't know if I'm getting ahead of myself because I know you wanted me to just answer the question of what happened, but I have a question for Andrew about that. But yeah. So I had the RPLND.
No, no. What's your question?
Yeah. So I'm sure that getting the RPLND was the right thing to do. I'm sure that based on the guidelines, the data, the information, everything, it was like the correct decision to make. I think what it was not clear to me exactly why, but I just had tremendous trust in my team and the and Dr. Einhorn and confirming it. But I don't know if you, Andrew, would be able to explain to me like why, because what I was told is that I had, even though like I had such a great response, and I still had a few spots, I think one in particular that was over a size limit, and they wanted to make sure there was not any residual cancer in that. And then the second part of this question is after I had the RPLND and they took out, I mean, not just that huge lymph node, but all of the lymph nodes and did all the pathology analysis. I think in that giant one, they found that there was like one, it said something like 1% teratoma. Like, I'm curious, like, does that mean that if I had left that in there, it would have eventually grown and turned into some other cancer, or the cancer would have come back? Or, I mean, obviously, even if it was the right decision, does that show that actually I could have just left that in there and like I would have been fine and I didn't need to have the RPLND with the benefit of 2020 hindsight? What is your understanding, or for someone that would be facing this decision, how is that evaluated?
Absolutely. This is actually a big area of, I would say, ongoing research and knowledge gap in testicular cancer management still in 2025 is, selecting patients for surgery after chemotherapy who have non-seminoma, which is what you had. So, sort of stepping back to the guidelines and the rationale for the recommendation for surgery. So, patients who have non-seminoma that's stage 2 or stage 3 after finishing chemotherapy should have a CT scan to basically reevaluate everything. And if there are any residual masses, according to the guidelines, over 1 centimeter, those should be resected or removed with surgery. The reason is that we know patients who have one subtype of non-seminoma, for example, embryonal carcinoma, can have any of the other types of germ cell tumor in other places in the body. And so there's one specific type that's called teratoma that does not respond to chemotherapy at all. The only way to treat it is with surgery to remove it. And so the reason for doing surgery like an RPLND is to remove lymph nodes where there could be teratoma hiding that basically is left over after the chemotherapy. Now, what happens to teratoma? Why do we care about it? Sort of two reasons. It is very slow growing, but over time, if it's left in place, it can invade neighboring structures like the aorta, the vena cava, kidneys, intestines, and it can actually become impossible to remove with surgery if it gets too big. The other thing is that, if you Google a picture of a teratoma from a surgery, you can see, what is it? Well, teratoma is basically a big mixture of normal human tissue that's in a sort of disorganized mess. And so muscle, intestines, nerves, hair, skin, all just jumbled together in sort of a chaos. It's like it was supposed to become a person, but it wasn't put together correctly. And so what that means is that the DNA of in a teratoma is inherently unstable, and so it can harbor and over time spawn very aggressive cancers. So we call that somatic transformation. When that happens, if those cancers spread outside of the place where they started within the teratoma, they're very hard to treat. Typically not very chemotherapy responsive and can sometimes be very aggressive and spread quickly. And so because of that, if patients have masses or lymph nodes after chemotherapy that are bigger than a centimeter, we typically will recommend surgery to remove them if a patient had non-seminoma to begin with. Now, where the knowledge gap comes is when we do those surgeries, at least in the case of RPLND, we find that 40 to 50% of patients have actually only dead cancer in those lymph nodes, no teratoma, no other types of germ cell tumor. And so that means, in theory, we're doing unnecessary surgery on 40 to 50% of patients. Unfortunately, right now, we do not have a way other than doing the surgery itself and looking at all the lymph nodes under the microscope to determine who actually has teratoma or other cancer left over in those lymph nodes. And so, we recommend surgery for everyone currently, and that, based on what you're describing, that was certainly the right decision for you. Really, the key, this is a major surgery, and it should be done by a surgeon who does it frequently and is highly experienced, and preferably at a cancer center that sees patients in this situation very regularly.
Yeah, and it's interesting because we talk about how cancer is not just cancer. And right now, there's a lot of medical misinformation out there about this or that cures cancer, or, here's what you should do to prevent cancer. But cancer is a constellation of diseases. We just use it. It's really kind of a descriptive term, in my opinion, describe something that grows uncontrollably. But just like your car can be broken for, a million different ways, a cancer can occur in a million different ways. But it's kind of rare that we have a type of cancer where the subtypes can coexist together. Like lung cancer, we tend to get one subtype at a time. Occasionally you'll get two, but in testicular cancer, we have guidelines around the fact that they're commonly observed together. So I think it's just another testament that cancer is super complex. And we have to have I suppose, a healthy understanding and appreciation for just how complex it is. But Jon, you had the surgery, you had the RPLND. How did it go?
It was rough. Now, for context, there's no way for me to reflect on the RPLND in isolation because Kyle, as I think you know, right? I actually, so story for another podcast episode, but I actually had two cancers concurrently. So I actually had the RPLND at the same time that I had a Whipple procedure. So I had surgeon scrub in for the RPLND, then he scrubbed out, and then the Whipple surgeon scrubbed in and did Whipple on me. So I don't know, obviously it was a horrific, hellish recovery, and I don't know, to what extent that was because of the RPLND, because of Whipple, or both. But what I can say with regard to the RPLND is that one of the most challenging issues for me in my recovery was it was extremely painful for me to lie down on my back in that sort of lower back of my abdomen, which I assume is the retroperitoneum, which the surgery was taking place. And I'm assuming that's because of that surgery that I had that phenomenon. And so for about 6 weeks, it was excruciatingly painful for me to lay down in bed at night. Which is obviously challenging.
Yeah, and it would be hard for me to tease apart those symptoms because the Whipple, folks listening, you may not know, but the Whipple is probably one of the more aggressive surgeries we do. You take out part of the pancreas, takes out a lot of bowel, and the recovery is a beast. The surgery is very long. They're very, very aggressive surgeries. So Andrew, maybe you could speak to then a little bit. What would someone expect for the ARPA? Let me start over there after swallowing my tongue. What should someone expect if they're anticipating getting an RPLND surgery?
The recovery depends a little bit on the approach that's taken to the surgery. Some surgeons do these procedures using minimally invasive techniques, which may shorten the recovery time, but that's not always appropriate for every case. Typically, RPLNDs are done through a pretty large incision in the abdomen, and recovery involves, at least at our institution, several days in the hospital, close follow-up with the surgeon afterwards, pain medication, potentially placement of small tubes coming out of the skin as drains to basically allow for healing and some of that excess fluid from the surgery to escape the body. So it's definitely a big surgery that takes a while to recover from, but patients will typically make it through and just need to expect up front that it won't be a walk in the park, I would say.
Can I ask a follow-up question?
Sure.
So after an RPLND, two questions. One's like sort of a short-term effect question. There's a long-term effect question. In the short term, I was told, and I think apparently my surgeon, who's quite well known, has become famous for this, put me on like an almost no-fat diet for a month after, to minimize the risk of ascites. Is that is that unnecessary? Because I mean, obviously, in the grand scheme of things, this was not near anywhere close to the top of the list of most unpleasant things about the experience. But I was just like, this seems just so ridiculous. So that's the short-term question. The long-term question is there any long-term effect? I wasn't told that there was. Is there any long-term effect to losing those lymph nodes? I know you mentioned earlier that they're part of the immune system.
Yeah, sure. So as far as the low-fat diet goes, the reason for that is that this surgery to remove the lymph nodes in the back of the abdomen has a risk of disrupting the ducts that carry basically lymph fluid, and so that can cause what's called a chyle leak, and that's where a very fatty type of fluid leaks into the abdomen and can cause swelling and discomfort. And so, one of the treatments for that, if it happens, is a low-fat diet, basically to sort of reduce the production of those fats that accumulate in that fluid. And so, it sounds like your surgeon in particular was concerned enough about this to just sort of recommend it to every patient, which it makes sense. I certainly have seen patients who've had chyle leak, and it's not a pleasant experience when it happens. So that'd be my answer to that question. As far as long-term effects, removing the lymph nodes themselves, other than the risk of chyle leak that I sort of just mentioned, the immune system has a lot of lymph structures, and so it's able to fight infections very well, even after those lymph nodes are removed. There certainly is a risk of damage to the nerves that control ejaculation, which run through the same area where those retroperitoneal lymph nodes are located. And so um, some patients will be left with some, sexual dysfunction after the surgery. So that's a possible long-term effect as well. And important to just discuss with the surgeon, what techniques will be used, what can be done, if anything, to mitigate that risk. But of course, the number one goal of the surgery is to remove any cancer that might be left over. And so sometimes that's an unavoidable consequence of the surgery.
Yeah, and I definitely want to get into the side effects of these surgeries because they're not trivial. But I'm not sure we have time for this one today, so people have to stay tuned. Um, Andrew, just kind of quick follow-up questions for those who are who have been treated for testicular cancer. What type of monitoring should they do?
So we have pretty good guidelines that tell us, depending on different situations, how frequently we should be checking tumor marker labs, doing a physical exam, doing chest x-rays or potentially CT scans. Every case is a little bit different, but more than anything, it's seeing an oncologist who's familiar with the guidelines and following them. Nowadays, we're sometimes able to use MRIs of the abdomen and pelvis instead of CT scans to decrease radiation exposure in the long term, which is a nice tool to have available. And then the other thing for patients themselves would be, first of all, doing monthly testicular self-exams on the remaining testicle. So we know there's about a 2% lifetime risk of having a cancer in the other testicle if you've had one testicular cancer. And so just continuing to monitor for that and seek, prompt medical attention if you notice anything unusual. And then the other thing is that we know, especially for patients who've received cisplatin-based chemotherapy like BEP, there is increased risk in the long term of cardiovascular disease. So heart attack, stroke, high cholesterol, kind of all things in those areas. And so having a good primary care physician, doing all the normal recommended health screenings on a regular basis, eating a healthy diet, maintaining a healthy weight and exercise routine are really important as well for our patients in the long term.
Okay, and then who is most at risk for developing testicular cancer, and what should they do to screen themselves?
So it's really recommended for all men, starting with puberty all the way up. I would say there's probably not an upper age limit, but perhaps 45 would be a reasonable one to do monthly testicular self-exams. So this basically is just a simple procedure where after a warm shower, when the scrotum and testicles are relaxed, to stand in front of a mirror, visually inspect the testicles to look for any abnormalities, and then palpate each testicle separately to feel for any lumps, bumps, swelling, firmness, anything unusual or uncomfortable. As far as who's at risk for testicular cancer, we know that having a first-degree male relative with testicular cancer does increase a person's risk. We know that having had a history of an undescended testicle or a currently undescended testicle is a risk for testicular cancer. There are some genetic syndromes that are relatively rare that also increase risk of testicular cancer.
Okay, and John's pretty young. Testicular cancer, I think, is I'd say one of the fewer cancers that we see in young adults commonly.
Sure.
Do you know the rough median age?
Yeah, absolutely. So I tell my patients the average age of diagnosis is 27. And it is the most common cancer in men ages 15 to 35. It's also actually the leading cause of cancer death in terms of life years lost after pediatric cancers. So if don't consider cancers that affect children under the age of 18, because our patients with testicular cancer are so young, when we do lose patients to this cancer, it's of many years of life lost. And so cumulatively, it's actually the highest number of life years lost of any cancer that affects adults. I've seen patients in my clinic up to age 75 with testicular cancer, and so it is possible even for older men to develop this disease. But most commonly, it's men in their 20s and 30s.
Yeah, I remember I went for a screening exam because I was concerned about a mass myself when I was younger, when I was in my early 20s, and I thought, no way, I'm way too young to get a cancer. And it wasn't a cancer, but they were like, no, you're exactly who we would expect to get it. And that surprised me. So I think it's helpful for folks to hear that. I didn't know that at the time. Jon, for anyone who's been diagnosed with testicular cancer or is worried they may have testicular cancer, what advice would you give them?
My advice would be something that I think Andrew or both of you guys alluded to earlier, which is the importance of being treated at a center that's high volume and expert and treats something like this all the time. I think, obviously, in any cancer, you want to make sure that you're getting the best possible treatment in a as timely as possible, in a large system like healthcare. I think finding a doctor, a physician, a team where you have a sense of trust and ideally, preferably also that communication like we spoke about earlier in terms of those conversations, shared decision making, in terms of, because obviously the treatment is severe and complex.
No, makes sense to me. And Andrew, any other last comments before we cut it?
Yeah, no, I would just really echo what you're saying, John. We actually have pretty good data that says that patients, even with stage 1 or early stage testicular cancer, actually have improved survival if they're treated at high volume cancer centers. And so, some patients maybe aren't able to receive all of their treatment at a high volume cancer center, but even receiving a simple, second opinion or evaluation or look over everything can be really valuable. For making sure treatment's being delivered adequately in a guideline-directed way, and also just for kind of peace of mind and comfort for patients.
Well, I think that sounds as great a place to cut it as anywhere. Jon, Andrew, thank you both so much for coming on. You're both busy guys, and hopefully this was helpful for a lot of folks. Everyone, if you like this, remember to like and subscribe to Cracking Cancer. You can go to crackingcancer.org for more information. All right, bye everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.